Welcome to Duke Spine Institute. It is Tuesday, February 11, 2025. I'm Dr. Ara Duke-Majin, CEO and founder. We are streaming live spine surgery. Today, we have our second case, and this patient comes from Georgia to Florida for our endoscopic spine surgery. He has a herniated disc in the thoracic spine, T8-9, worse on the left side. Pain radiates to the left. And we're going to be going in with the endoscope using a laser to repair this disc to get rid of that pain. Now, he came with an MRI showing one herniated disc, T8-9. That's what we're going to go fix. It's through the left side, transforaminal. This is the only place in the United States that I know of that you're going to see this type of surgery done in the thoracic spine, as we are the pioneers who first did it. And we've been doing it now for about 6 years. All right, let's carry on. If you have questions, ask them. In the meantime, I'm going to have, while we're getting into the disc, I'm going to have Henry show you guys a video on some of the common causes of back pain. Thank you. I'm Dr. Ara Duke-Majin with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, touches the vertebral bodies. With trauma, can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. Okay, we're focused right now on getting into the disc. We're off on orbit, so let's fix the orbit. Oh yeah, that's better too. You can see the disc right in front of the needle. If you have questions, feel free to type them up. I'll do my best to answer. Let's try to get those pedicles lined up. You see right in front of the needle there, Jordan? Those pedicles are off on orbit, and they're also off on WAG. How are we doing on arm boards? Arm boards are far enough north? Yeah. All right, let's do, I think we went the wrong way, but let's do a little bit more that way, and just to verify. It's actually, what do you think? Getting worse? Or did that get better? I think it got better too. So let's stay there. And I think the WAG is okay too at this point. It's not horrible. So folks, we're using the X-ray machine to navigate the needle to the back of the disc where the herniation is. That's what we're doing right now as we speak. And this is the hardest part of the entire surgery. Shot? Okay. Shot? Give me an AP. Now the patient is awake, they're not intubated, they're on propofol, so they're sedated, they're sleepy. Twilight we call it, and I need his cooperation. There we go, it looks pretty good. Looking good, our lung fields are nice and full. We want to avoid any kind of lung issues. Any questions?
Yes,
John?
We have a question coming from Lanu on YouTube.
Hi Lanu, welcome.
Asking about the pain for facet joints. When you eliminate the nerves, the pain is gone. How come the nerves never grow back?
They don't grow back because of the way that I kill the nerves is different than what everybody else does. It's called the Duke plasma rhizotomy. I actually cut through the pain nerve rather than just burning next to it. That is our patented technique. Okay, I'm encountering something here. I think it's the transverse process. I may need to be a little bit higher. So I can't seem to get around it. Shot? I need to be a little bit higher. That's the problem. I'm going to start a little bit higher. Try again. Shot? 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 AP? It's the way I destroy the pain nerve that's different than what everybody else does. It's a true destruction of the nerve. Lateral. If you watch our Duke plasma rhizotomy video, you'll see exactly what I do. It's in there. It's in the animation. If you watch the animation shows you exactly what I do. Shot? All right. So far, so good. Our patient is comfortably resting. I've just got to get around this posterior facet complex and we should be all right. Lay still. Shot.
At this moment, no current questions. So in the
I
meantime,
think
why
I'm
don't we
too medial.
show the audience of how
Yeah,
it is?
Go ahead, Henry. Just do your thing. I got to work here.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic thoracic back pain. The inflamed annular tear causes thoracic back pain. A 1/4-inch size skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. The advantages with the Duke laser disc repair is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK 349-6922.
All right. We're trying to get into this disc at T8-9. He's not making it easy for us. Shot. 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 AP. Yeah, the midline. Really? I would say more here, right?
Yeah, I feel like
Let me see.
I feel it's fine.
Yeah, it's right here. Let's try again, shot. All right, 12. All right, we need to figure out where 8-9 is on this new view. So come south a little bit, shot. That's probably 12, 11, 10, 9, 8. I think that's 8-9 right there. Let's go back up to 8-9 so I can see it. Shot. 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 Let's go AP. Quickly. I think I'm hitting the TP. be a little bit lower than. Shot. That's too low. Give me a lateral view. Twelve, 11, 10, 9, 8. Shot. Shot. Well, I'm lined up with the disc. 12, 11, 10, 9, 8, 8, 9. That's what we're doing. I'm just not able to get around this. I think you're off on orbits again. I mean, you got to give me the right orbital picture. That's, I think, better. That's better. Yep. Yeah, that's better. All right, so AP, question is, are we too medial? And therefore, we're not able to get around the spine. Quick AP. Shot. Yep, too medial. That's good. That answers that question. So we need to reposition. Shot. Shot. Still hitting this too medial. Shot. 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 Too superior. AP. I'm being forced superior. Uh-huh. Twelve, 11, 10, 9, 8. Just seem to be getting forced superiorly. Shot. Pressure of your finger. Shot. Shot. There we go. Now we're making progress. That's what I needed to see. You just have to get around this. Shot. AP. Sometimes you have to move around and try different entry points, different trajectories to get to the disc. Alright, we're still pretty far off. Let's see where we are on lateral view. Something. So we're still off on orbit. I wonder if you can fix the orbit. I've got to have an accurate orbital picture. Other way. A little more. I don't know. Seems like we went the opposite direction. What do you think? More better? More better? I don't know. I'm not convinced. I think we're still off. So let's try something a little, raise one side. To me, I think that's better. You don't think so? You do?
I do, yes.
Alright, let's see what that is. Give me hitting bone. Shot. Question is, I must be hitting the top of the pedicle. So let's go back to an AP view. 12, 11, 10, 9, 8. We're at the right disc, which is good. We're almost there. I just feel like we're a little bit lateral. I want to be more medial, but there's something not letting me go more medial. It feels like bone spur. Shot. That shows me right there. Give me an AP. But on the AP, I'm not. Nope. This could be just the rib head. All right, back to a lateral. I'm gonna have to try a different entry point or trajectory. Shot. First start with a different trajectory, but I don't think this trajectory will work, but we'll try it since we're here. So I'm hitting bone again. Shot. Just cannot get it more medially. Shot. AP. May have to start more medial on him. And that looks good, but I'm hitting bone. I'm hitting that rib head. That's got to be what it is. So I'll try one more time higher. Shot. Again, bone. Shot. 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 AP. Well, yeah, I mean the target hasn't changed, right? It's the back of the disc, but the problem is it's the rib head that I'm getting around, and right now I'm around it, but I'm still not where I want to be. I'm still hitting bone. So too medial on the AP. I have to try to be a little bit more lateral. Shot. But that pushes me north where I don't want to go. Shot. Yeah. I don't want to be that north with the tip. I feel the bone pushing it. That's the problem. It's really restricting what I can do. The anatomy. Shot. Shot. This might be it. We'll see. If I can just get around that rib head. That's looking a little bit better. AP. How is he doing? That's fine, but he's breathing good, ventilation good, oxygenation good, vitals are good. All right. I appreciate that. That's helped. Not having a moving target's always better. But there's just all this arthritis here. I don't know. I'm not sure. But I'm encountering something here. Give me an AP again. I'm sitting right here. I can't really tell because of the diaphragm. Exactly. I may be at the back of the disc, but then I'm too lateral. Again, too lateral because that rib head, that damn rib head is forcing me. Let's see if I can get a little bit more medial. I'm slipping around it, Sean. It's just constant bone. There's just no give. There's no passage. I mean, if anything, that looks the best we've had it. But I'm still not entirely happy with it. AP. Yeah. Way too lateral. Too lateral. I have to go more medial if I'm gonna want to get this shot. And I just don't know that we have a path medial shot. Shot. I'm not feeling a path. Shot. Does have a fair amount of arthritis back here, which is surprising. Yeah. Maybe on the lateral we're a mile away. Show me an AP. See, on the AP we're right where we want to be, but on the lateral we're too far. When we're where we want to be on the lateral, we're not where we want to be on the AP. This is his rib is pushing me away. How else could I change this trajectory? I guess I could try a little bit south, coming from below a little bit, and see, since I can't get there from the other place, I'm going to try coming one just underneath. Maybe that'll allow me. Shot. 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 AP. No. We're still too far lateral again. It's the same situation. There's something there blocking us. Bony. That's it right there? That's the lateral?
Yes, sir.
Well, you know what? It could be. It could very well be that we may be able to make this work. Again, I'm hitting that hard bone. Shot. All right, so we've made some progress. Let's see on the other view. Do one more lateral, and then let's get an AP and see where we are. I feel like this is moving. Go ahead, shot. Maybe it was with inspiration. We're just too far away on the lateral. Go back to the, sorry, we're too far away on the AP. We're too lateral to the spine. I just cannot get any more medial. Nope, it's not budging. Alright. No space in there. I think you're off on wag a little bit. Let's get the pedicles lined up. Shot. That's better. It gives us a better idea about how far away we are still. See that? Huh? I just can't get closer. It's just there's no hole. There's no path. There's no gap between these bones. Let me try. Don't want to go any further lateral. And I don't think going more medial has helped. We've tried so many different positions. Let's see. Yeah. I'm not sure how much lower I can go. I don't think I can go any lower. I mean, we tried upper, we tried neutral, we tried lower. I'll just try one more, but I just don't know that this is going to work. Shot. 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 In that same bone again. There's just no way around it. Shot. It's the, in this case, the rib head and facet. AP. We're more medial, but we're right on the facet. So it's kind of like the rib head and the facet are for some reason ganging up and blocking our access to the disc. It's just his anatomy. And it's not creating any way for me to get there. Shot? There's just no way around it. Maybe. Let's see what it's doing. AP. I mean, it looks good on the lateral, but the AP is it's probably gonna be pushed too far to the side of the spine. And we can't proceed that way, but maybe I can. Oh, actually, that looks pretty good. That looks pretty damn good right there. I could live with that. If we can make that work, let's go lateral again. Yeah, it looks pretty damn good right there. We might have found our path. All right, let's just verify levels one more time. I want an AP view. Before we do this, I want to make 100% sure we're at the right level. So we're 8-9, everyone agree? 8-9? Yes, sir. Let's see what we got. 12, 11, 10, 9, 8. 12, 11, count for us, pedicles. 12, 11, 10, 9, 8. So it's 8-9, you agree? I agree, you agree, we all agree, 8-9. All right, let's see if we can get this. We might be there. Maybe your anesthesia magic helped us. Well, yeah, that's fine. That's fine. Let me just triple check everything. Shot? Yeah, it feels like disc to me. Feels soft. I think we're there. It feels like scar tissue disc. Yeah, we're there. That's amazing. I don't know how we did that. That is a miracle. Thank God. That's all I can say. I don't know how we got in. I mean, perseverance, obviously. Okay, well,
How you doing, my friend? You okay?
take your time.
Ask
So,
me a few questions here. You doing all
folks, it took us a lot longer than normal, but you know, we persevered and we got lucky. To be honest, lucky. Honestly, sometimes don't know how we do it, but this is the T8-9 thoracic disc. His MRI shows he's got a herniation, and you can see there's evidence of inflammation here. He's had really bad back pain for 2 years, right here, like literally right there. You can see the X mark, right, from before surgery.
Yes, we can.
It's literally lined up with the disc. So I believe we're at the right place. The other discs look okay on the MRI. So hopefully this is it. Let me know when he's awake. Are you awake?
right? How you doing, my friend? You okay?
We'll give him another minute. So, Henry, let's show our audience how herniated discs like T8-9 herniation can cause so much localized pain for patients right in their spine.
Copy that.
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922. Disc injuries are a common cause of chronic thoracic back pain. The inflamed annular tear causes thoracic back pain. A 1/4-inch size skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. The advantages with the Duke laser disc repair is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-BACK 349-6922.
Okay, welcome back. We just tested the disc to see if it was painful, and it sure was, but he couldn't give us a number. So we'll call it concordant, and we just won't give it a number. We're going to proceed with our endoscopic procedure. Yeah, no, I woke him up. And right now we're making a 4mm incision, taking out the needle that we use to access the disc transforaminal and the herniation, and we're going to place a dilator over the guide wire to create a small path for our tube. The surgery is relatively bloodless shot. We were able to finally get into the disc. There was a small path. Now he wants to wake up. Yeah. Lay still, you're doing great. Yeah. All right. I'll take your questions.
Alrighty, next question coming from Lanu once more on YouTube, asking, I know you are not a heart surgeon and might not know about the coronary artery bypass and valve repair, but have you ever heard of a Da Vinci surgical system?
Yes, I've heard of the Da Vinci robotic system. Shot? Wait. All right. Yep. Hold on. All right, we're inside the tear and the herniation right now at T8-9. Once again, we did our discogram. We did not get a number from the patient, which we like to get, but we did get a response, and it was painful and concordant. Patient was a little bit too sleepy at the time to give us a number. Good news, he's stable, everything's going well. We're going to start the laser disc repair. Very difficult disc to access, technically, from my standpoint. Was not easy. Probably one of the most difficult I've done, if not the most difficult. And we finally got lucky. We were able to get in there and get it done. That's the inside of the disc right there. As a matter of fact, you're looking at the tear inside the disc, and it's in the wall of the disc. You can see the inflammation, the pink stuff. So I feel really good, even though I didn't get a number out of him. I feel like this is definitely inflamed and causing his pain. You can see all that there, scar tissue from chronic inflammation. So these are all good signs that we're in the right place to fix the right disc. Any other questions?
Yes, these next two questions are coming from MSM on YouTube.
Hello, MSM. Welcome.
First question asking, we appreciate you and your team's great work. Are you planning to keep your clinic open and train your replacement when you retire?
Yes, I am. As a matter of fact, great question. So the question is about succession. What do you do, Dr. Duke? You've pioneered all these amazing techniques. They're curing people's pain that nobody else in the world can do. What I need truly is I need some help financially. I will not be bashful about it, but I'm not gonna, I can't afford to fund people's surgeries from my own savings. That's really what it comes down to. I'm already pretty much giving all my time away. So what I need is I need some financial support. And if we had somebody to make a contribution to help us, because unfortunately this is a very expensive place to run. And every medical clinic is expensive, by the way. This is no exception. We are not exceptionally expensive. It's just expensive. Hospitals like ours, we basically run a hospital minus the emergency room. But a hospital, the most expensive part of a hospital is the operating room, followed by the intensive care unit. And our expenses are very high because we basically have an intensive care unit and we have an operating room. The recovery room is an intensive care unit. You're monitoring people's vitals. You have all the expensive equipment, drugs, stuff available, staff. So we need support. So let's just pretend for a moment that the money wasn't an issue and that we had all the financial support we can get. I would start training doctors, because what we really need is more awareness so that these treatments are available so that we get more people coming. And then I can start training more doctors to do the procedure. Now, who is my number one choice right now is my son. I don't know if he's going to go into neurosurgery and he's going to follow and become a surgeon, but that's my number one choice. My daughter, number two. Why? Because I know who they are. They're very smart. They're very capable. They would make great surgeons, make great doctors. They would run the business quite well. But we need more doctors. So if I had to choose doctors, I would choose them based on their commitment to the same values and principles that I have, okay, which is a patient-first attitude to do what's best for the patient, not what's best for the industry. Too many doctors do what's best for the industry and for themselves. They make choices about what treatments to give patients that are best for them, the doctor, not for the patient. And doctors are supposed to put the patient's needs first and foremost, and do what's best for the patient. But that's not happening. So I need a doctor to train that has my values, is wanting to do what's best for the patient, and even when I'm gone, they'll continue to do that. Unfortunately, medicine sometimes attracts the wrong kind of people, and you don't always have good-hearted people that come into medicine. There's some very ugly people in medicine. And so I wouldn't want to train one of them. I don't want to give them this technique. It will be mishandled. So quality control, very important. That's number one on my list for succession. I want someone who's going to do the surgery properly, carefully, meticulously, and if there is a complication, they're able to handle it and not botch it. You know, they can get in there and fix the problem quickly and minimize the damage, okay? So you need a really, really good surgeon. That's who I'm willing to train. But they also have to have principles and values that match mine. Yeah, I'm open to training people, but we also need volume. I can't afford another surgeon right now, financially. We don't have the money. So even if I wanted another surgeon, I can't pay for them. We don't have enough business. We don't have enough revenue. You know, in the end, we're a company, we're a business, not just a medical office. We're a business. We have to make enough money to cover our costs. And if we don't, then basically we go out of business. And being out of business is not good for anybody. So we don't have enough revenue yet that we don't have to worry about revenue, if that makes sense. The insurance companies do not do anything to help us succeed. The hospitals do nothing to help us succeed because we're their competition. The companies that manufacture screws, rods, stem cells, cages, barricade device, you name it, whatever those companies don't want us to succeed, they give us nothing. The only entities that want us to succeed today are our employees and our patients. And the employees don't pay us. They take their money. And the patients are the only ones who pay, along with some insurances. But we need more support. Then we can do more training. This is the best we can do for today. Any other questions?
Yes. Next
We have
question.
8 minutes left.
Coming from MSM once more on YouTube, asking, when's your spine video coming out? I'm looking forward to watching it. Thank you. I think they meant the movie.
Yeah, the movie. Yeah, MSM, the Spine Scam movie is coming out. We don't have a date yet, but this week is supposed to be completed, the movie, with the final sound editing. And assuming my director and producer is, of course, telling me the truth, which I have no reason to believe he's not. He's a good man, and he's invested in the movie as much as I have. He's learned a lot. He believes in the message. So I have to talk to him. I need to give him a call and find out if we're done. And then the next step after that is going to be to find a streamer who will pay for it to be streamed. And we're hoping Netflix, but it could be HBO, and it could be, I doubt Disney, but it could be Disney, you know, we'll see. But there needs to be a streamer who basically pays for the movie, who buys it. So we have to sell it. That's going to take some time. And then we're hoping that they buy a series rather than just an individual movie, so that we can make more of these movies. and we can do more teaching of the public about what's happening, because there's a lot of messages that we need to get out through these movies. So should be very interesting and entertaining, but also educational. So we just have to wait and see if they're going to want a series or they're going to want to just do one movie. A lot of questions still before we release the movie. So yes, the movie's almost done. I can talk to Jeff and find out. I just don't know that he's going to want to put it on our website yet until we have an opportunity to stream it first on Netflix.
We have another question
Sure.
coming from Lanu once more on YouTube.
Sure, hi.
Saying a question for Henry. Has any newspaper or news outlets ever interviewed Duke Spine Institute? For as long as I've been working here, which would be 3 years in April, nobody's come around, but there have been plaques and stuff recognized by our local government and our county saying that, acknowledging this place. So I think there was like one or two newspaper articles like plaqued up in one of our hallways. So other than that, that's pretty much that. Next question coming from Ramazan on YouTube.
Hi, Ramazan, welcome.
Asking, Doctor, your all treatment are so magical, amazing technique, really for futures treatment. For me, you are a second Albert Einstein. Thank you, Dr. Duke.
Thank you. You put a smile on my face. Thank you so much. I appreciate it. And I just wish the rest of the world knew about our treatments so that people would come and get taken care of and get fixed, and the more people that know about it, the more people we can help, and the more people I feel would benefit from our treatments. So this is the disc we were working on, T8-9, and it looks like to me it is 100% damaged. This is a injured disc. This is the source of the patient's pain. I'm very glad we got the right one. And you can see the little bit of blue is the herniation within the tear. You can see a lot of calcium here. We're just about finished. I'm at the back side of the disc right now. There's not much left to fix. This is the back of the tear, the back of the herniation. And you can see there's some bone spur here. That's calcium right there. Just about done though. I think I've gotten most of it cleaned out. So this should get rid of the pain from this disc. Now he's got a few other discs that look a little concerning, but they're not horrible looking. Hopefully they're not symptomatic. When I asked him where his pain was, he pointed to this spot, and this lines up exactly with T8-9 where we're operating. So we had an X. If you look back at the video, you'll see an X on his skin right where he had the most pain, and that's exactly where T8-9 is. So we're hoping this is it. I got about 1 minute left and we're done. So if you have any other questions, ask me now. But surgery went very well for him, and I'm just going to be finishing touches right here.
No current questions, but we do have a...
Let him go. Let him go. I'll just see him tomorrow. Thanks. Go ahead.
We just got a question, but this comment is coming from MSM once more on YouTube, saying, you fixed my wife's back. I discovered you in December of 24. She is pain-free and is sleeping through the night for the first time in 20 plus years. I can't thank you and your team enough. You guys are great people.
Oh, thank you so much. We appreciate it. Yes, and I'm glad you appreciate the team. It is a team effort. These guys make me look like a rock star, though I'm not. They make me look good. I couldn't do it without them. So I'm so happy for her, and I hope you guys enjoy your lives together and you get the most out of life and you have no reservations or issues. So that's my hopes for you and your family. Thank you for sharing your experience. There's always people asking, can we turn the suction back on?
Suction on, please.
There's always people asking, do you know can you share any patients' stories from a year ago or 2 years ago or whatever? And so thank you for sharing. All right. Yeah, go ahead.
Lastly, just coming from Pawn Lust on YouTube, asking, is a T5, 6, or T6-7 the hardest? What about muscle damage accessing it since there's so little space?
Yeah, so I don't know if there's one disc that's going to be the hardest. I would say the further up we go is going to be the hardest, like T1, 2, T2, 3, T3, 4. I would say anywhere from T1 to T5 is going to be the hardest because the way the spine compresses up there, it gets smaller. Much more difficult to get to. Thank God there's not a lot of herniations up there. This was a hard one for me, T8-9. Normally you wouldn't expect T8-9 to be hard, but the reason it was hard is his anatomy. His rib head comes around and attaches to the spine just near the transverse process. And I have to get around that thing. So I tried to go above it. It didn't work. And then I went below it and I got lucky. And we found somehow a tiny 0.5 millimeter of space. And we were able to get it done. But I don't know. I mean, I was almost ready to give up on that. I tried every single entry point and angle and trajectory. And got lucky at the end. All right, any other comments?
We do have a comment saying, coming from MSM once more on YouTube, saying, I already recommended Duke Spine to 2 people that I know. Hopefully they'll submit their MRIs to you soon. I'll continue to refer people to you.
You are the best. We really appreciate it. Every referral is so helpful, and consider it for your friends and family. All right, everybody, we'll be back shortly for one more surgery. What is the last case? Bilateral sacroiliac joint DPR and bilateral piriformis muscle release. Referred by a patient's family member for the next surgery. Have a wonderful afternoon. If you don't join us again, we'll be back shortly. Thank you.